My case for today is right coronary artery to right atrial fistula, role of multimodality imaging and percutaneous closure. We have a 60-year-old male with past medical history of non-insulin dependent diabetes, was referred to the cardiology office for new onset atrial fibrillation. The patient has been having shortness of breath for the last 6 months, so the decision was made for TEE cardioversion. The patient underwent TEE. His TEE showed low normal ejection fraction at 50%, normal RV function, mild biatrial enlargement. But the striking finding was there is a 4 by 4 centimeter structure adjacent to the aorta, as we can see here in the mid-esophageal short axis view, and we can appreciate this more in this clip. There is flow from this structure to the right atrium, as we can see here. More of the view, bicaval view as well, it showed evidence of Doppler flow. As we can see here as well in this clip, there is a flow from the structure to the right atrium. So for that reason, the patient was sent to the ED for further assessment. He underwent CT chest. His CT chest showed right atrial fistula arising from right coronary artery to right atrial fistula. We can appreciate more on the coronal view here. There's this fistula arising from the RCA to the RA. Patient was scheduled for cardiac MRI as an outpatient. As we can see here in this 4-chamber view, in the cine image, there's this draining fistula into right atrium. Shunt fraction was calculated to be 1.7. Afterwards, the patient underwent left heart cath via radial axis. In his view, as we can see here in both view, in the right anterior oblique view, we can see there's a fistula arising from the RCA and draining into the right atrium with aneurysmal dilatation as well. In this view as well, we can appreciate the fistula draining into the right atrium. At this point, structural team was consulted, and they decided upon percutaneous option for him, and the patient underwent percutaneous closure via 16 millimeter AVP plug and coils. This is the image after the coils and plug, and we can appreciate here the plugs and the coils in the mid RCA. There was no flow in the fistula after placing the coils and the plug, as we can see as well, and there's a flow in the distal RCA. So there's no compromisation for the flow in the distal RCA, and the coils and plugs, they were able to stop the flow in the fistula. The patient developed AFib post-cath, and the plan was for repeat TE cardioversion as well. Echo showed ejection fraction of 41, and the patient was complaining of pleuritic chest pain. In the setting of pericardial effusion, he was started on colchicine. Then the patient was discharged on aspirin, apixaban, and Plavix, and the plan was to discontinue Plavix in a month afterwards. Follow-up for the patient, he reported improved fatigue, chest X-ray was done, afterwards revealed stable placement of the coil, repeated cardiac MRI showed no flow, and the shunt fraction of 1.2. A little bit about coronary artery fistula. This kind of coronary artery fistula, called cameral coronary artery fistula, arising from coronary artery draining into cardiac chambers, can be congenital or acquired. Most origination site is RCA, and most termination site as well is the right ventricle. Clinical manifestation can be symptomatic versus asymptomatic. If they present with symptoms, they can present with the steel phenomena, with the heart failure symptoms, orthopnea, PND, arrhythmia, as we saw the patient presented with atrial fibrillation. They can present with pulmonary hypertension and endocarditis. Treatment, it depends if the patient, they are symptomatic versus asymptomatic, percutaneous versus surgical. The course, the tortuosity, and the coexistence of aneurysmal dilatation dictate the approach. If the patient has high flow, branching, and tortuosity, and there is as well a need for a cardiac surgery for valve replacement or such, so surgery would be in favor. Post-closure treatment, antiplatelets, prophylactic antibiotic for 6 months post-procedure. Thank you.
So I'm just curious, the decision for closure, I definitely think taking a percutaneous approach is very reasonable, unless, like you said, they had coexisting disease that needed to be treated surgically. But what was the decision between a vascular plug versus coils versus both?
Yeah, so at first they placed the coils, but there was still flow when they put the coils. They put multiple coils, and there was still flow. Then for that reason, they placed the plug afterwards.
Yeah, getting a 16 millimeter vascular plug into a coronary fistula may be challenging, because that's probably takes at least an 8 French guide, I'm guessing?
Yeah, they put 8 French, yes.
Yeah.
Did you guys, I mean, obviously you said that the structural team was consulted and made this decision. I'm assuming surgeons are part of that team, and was there any particular input from the surgeons in terms of what they would do and why you ended up going the percutaneous route?
Yeah, so the surgeon, they were part of the structural heart team. They said if there's like coexistence comorbidities, like if there's a valve, if there's anything in coronary artery disease, like atherosclerosis, anything like this, they would go with the surgery route. But they said they would, given his young age and like he's still 60, they said percutaneous would be preferable for him, and it showed like better outcome.
So one of the challenging things about coils is in big structures like this that are exposed to systemic pressure is they can recanalize. So I think when you do have something that has this degree of flow in it, using a combination of plugs and very large coils it can be real helpful to minimize that risk. We've got a handful of cases of mammary arteries that were sewn to veins on the cardiac, on the heart, that become extremely high flow fistulas. And in our experience, just putting either just a coil or just a plug, oftentimes these will recanalize. And so this is a case that you've got a nice result, but it's going to be somebody that's going to need to have long-term follow-up, because these can recanalize.
Yeah, I totally agree with that. And I think the other option is if you could lay out a view where, you know, this looked like it came off of the cusp. Is that correct? Not the right coronary itself?
Yeah.
Yeah. I mean, if it had come off the coronary, you have the option of putting a covered stent in the coronary, which is a lot easier to do and will get you a much better seal. Sometimes you, as Jason's saying, you need so many coils, you end up compressing the right atrium with just the coil burden. So it's nice to just seal off the neck of it if you can, but it doesn't seem like that was an option in this case.
Yeah, typically if I'm going to put a coil in something this big, I'll get a very large coil, like a 6 by 60 or an 8 by 80.
Yeah.
They can be a little bit hard to pack, and they need to obviously be detachable coils, not pushable coils. Right. Because you want to be able to manipulate it and make sure you get a good pack and not have this hanging up towards the aorta or near the right coronary artery.
Nice case.
Well done.
Very nice.
Thank you very much.
Thank you.